So next in line is Dr. Nagin Sharma. He's a medical oncologist from Delhi, and he'll be speaking on the neoadjuvant treatment with Disitamab Vedotin plus perioperative Toripalimab in patients with muscle-invasive bladder cancer with HER2 expression. This is the Phase II RC48-C017 trial.
Hello, good morning. So the title is that this abstract was published in GEO 2025. The neoadjuvant treatment with Disitamab Vedotin, which is nothing just a smart chemotherapy, which is directed against anti-HER2 with the perioperative Toripalimab, which is a PD-1 antagonist in a patient with muscle-invasive bladder cancer, who are having HER2 overexpression. This is a Phase II study, as presented in ASCO Genitourinary Symposium. So RC48 is a Disitamab Vedotin, which is used in the neoadjuvant setting, because we are already having EV trials in the metastatic setting. We are having sacituzumab govitecan, Trodelvy. This is there in the metastatic setting. That these drugs we are started using in the neoadjuvant setting. That Disitamab Vedotin, when combined with the perioperative Toripalimab in a muscle-invasive bladder cancer who are overexpressing HER2, what is the efficacy, the safety results of that? So as we know that cisplatin-based neoadjuvant chemotherapy followed by radical cystectomy is recommended for cisplatin-eligible patients with muscle-invasive bladder cancer. The immunotherapy-based neoadjuvant therapy has a significant impact on the treatment of most of the cancer. The Niagara study just demonstrated by Dr. Athera demonstrated that neoadjuvant durvalumab plus chemotherapy significantly improved the EFS, the overall survival in the operable muscle-invasive bladder cancer. The several clinical trials that combine immunotherapy with the antibody-drug conjugate in the neoadjuvant settings are ongoing. However, none of these trials have yet published their findings. Background is that the HER2 directed ADC such as Disitamab Vedotin plus and Disitamab Deruxtecan, which are used in breast cancers and other cancers, have emerged as effective treatment options for HER2 positive metastatic urothelial carcinoma who have failed the chemotherapy and immunotherapy. Disitamab Vedotin plus Toripalimab, these two drugs are combined together, have shown encouraging efficacy confirmed by objective response rate of 76.3% in patients with HER2 expression who are having a HER2 IHC 1+, 2+, or 3+ in Phase 1B and 2, that is RC48-C017 trial. The single-arm Phase II trial was conducted to evaluate the efficacy and safety of neoadjuvant DV, that is Disitamab Vedotin, plus perioperative Toripalimab in patients with HER2 positive or expression muscle-invasive bladder cancer. This is the study design, which has shown that those patients who are having histologically confirmed urothelial cancers, who are having a muscle-invasive bladder cancer of CT2 to T4A, N0, N1, and M0, who are eligible for radical cystectomy and pelvic lymph node dissection, or who are having a HER2 expression assessed by IHC on 1+, 2+, or 3+, DV at the dose of 2 mg per square weight plus Toripalimab was used at 3 mg per square weight Q2 weekly for 6 cycles in the neoadjuvant setting, followed by reassessment for the radical cystectomy, and then Toripalimab is continued for 20 cycles 2 weekly in the adjuvant setting. The primary endpoint of this trial was pathological CR rates as defined by YPT0N0. The secondary endpoint was pathological response rate, that is less than equal to YPT1, N0, M0, and even disease survival and overall survival and adverse events. The baseline characteristics, as we see, the majority of patients were of pure urothelial carcinoma, although urothelial carcinoma with other differentiation or the variants are also checked. That is, majority of them were either squamous, the glandular differentiation, micropapillary variant. We have to remember that micropapillary variant is having the highest percentage of HER2 expansion. Nearly 40% of patients of micropapillary variant will be having HER2 expansion. Majority of patients were in excellent performance status, and those patients who were having less than 60 GFR was 25%, that is 1/4, and nearly 75% of the patients were having a GFR of greater than 60 ml per minute. HER2 expression was 3+ in 31% of the patient, and it is 2+ in 57% of the patients. Remaining were having HER2 1+, and they have checked the PD-L1 percentage also. The majority of patients were having PD-L1 negativity, that is PD-L1 negative, which is 53%, and PD-L1 positivity rate was 27%. 63% were screened, and 47 were enrolled to receive the neoadjuvant treatment, and then 33 out of 47 underwent a radical cystectomy, and 14 did not undergo cystectomy. Majority of patients which they have received this treatment, they have got a good response. As you can see, the pathological rates, the median time to end of neoadjuvant treatment to RC was 5 weeks, and the pathological CR rates were 63.6% in YPT0N0 arm, and those patients who are having a YPT less than equal to 1 and 0, it is 75.8%. In subgroup analysis, the pathological CR rates for T2 and 0 patient appeared higher than those with other subgroups. The pathological CR rates were generally consistent with the patients with pure urothelial carcinoma and patients with urothelial carcinoma with other differentiation or variant histology. Majority of patients have got a very good response if it is CT2 and 0. It is 85.7%, and baseline pathological CR also were higher in pure histology. Other subgroups also were analyzed. The pathological CR in HER2 IHC3+ subgroup was numerically higher than those of IHC1+ or 2+ subgroups, regardless of the PD-L1 status. As you can see clearly, in those patients who are having a PD-L1 positivity, the pathological CR was nearly 100% if they are PD-L1 positive, and those who are having PD-L1 negativity, those patients who are having a HER2 3+, it is 83.6%. The EFS survival in the patient with received radical cystectomy, the median EFS has not yet reached after a median follow-up of 14.1 month. What about intention to treat population? The EFS is still not reached. That means these patients are doing better. And 12 months EFS rate was 90.5%, and 18 months EFS rate was 82.7%. The overall survival in this phase 2 intention to treat population have not yet reached, and 12 months median overall survival was seen in 95.5%. Post-operative complications, majority of patients, as assessed by the Clavin window, the post-operative complications were 1 or 2, that is 24.2% versus like 15.2%. And type of post-operative complications were like post-operative pain followed by stoma site infection or clotting disorder, and the lesser incidence of other complications were seen. Safety summary, majority of patients are tolerating it very well. The grade 3 side effects were seen in around 27% of the patient, and leading to discontinuation of the treatment, it is just 12.8%. Dose reduction was regarding 2.1% of the patients. Leading to the serious side events leading to the discontinuation of the study treatment is 17% of the patients. The treatment-related adverse events greater than or equal to 3 grade was 21.3%, and the serious adverse event was 12.8%. What were the most common treatment-related adverse events? That was alopecia, which was seen in 42.6%. Raised SGBT, SGOT are seen in around 34% of the patients, but it is very less as compared to the other drug. So to conclude, the RC48-C017, in which we have combined the Disitamab Vedotin along with that Toripalimab, is the first prospective study showing the ADC in combination with PD-1 antagonist as a perioperative treatment provided prominent outcomes in the operable muscle-invasive bladder cancer. The pathological CR rates were 63.6%. The 12 months EFS rate was 92.5%. The Neoadjuvant DV plus Toripalimab did not delay the RC procedure or impact the patient's ability to undergo radical cystectomy. Safety profile was manageable with no new safety signals. The results indicated that Neoadjuvant DV plus perioperative Toripalimab has promising efficacy and acceptable safety in patients with HER2 expressing muscle-invasive bladder cancer, warranting further investigation. Thank you. Thank you very much.
Thanks, Nagendra.